Choosing imaging is an important responsibility, but how do we do it? Our choices cannot be random or guesswork. The ACR Appropriateness criteria provides clinical decision support tools. It is the national standard for high-quality imaging care created by experts from multiple clinical specialties. To visit the site, enter ACR Appropriateness criteria in your browser. You'll arrive here, so click on Basic, and that brings you to a list of diagnostic categories beginning with breast, cardiac, and so on in alphabetical order. Under each category heading, there are a number of clinical topics. Let's scroll down and see musculoskeletal, where we see those topics, and chronic neck pain. We'll click on the narrative, and that opens a PDF that contains several variants of that clinical topic. So you choose a category, then a clinical topic, and finally a more specific variant that fits your patient's needs. Let's get oriented to the variant tables. First, the date of most recent revision is in the upper right. On the upper left is the clinical topic title. Below that are the more specific variant titles, one for each of the tables. These variants allow you to match your patient's situation precisely with the correct table. All tables are laid out the same way. The first column is a list of procedures to consider. The second column is the numerical appropriateness rating. The higher the number, the more appropriate the study. Tables are laid out with the most appropriate studies at the top, reflecting that they are the top choice. There is a scale at the bottom indicating scores of 1 through 3 are usually not appropriate, scores 7 through 9 are usually appropriate, and the scores in the middle might be in some circumstances. And the next column explains when studies with intermediate 4 through 6 appropriateness scores may be the most appropriate choice in a particular patient. The last column describes relative radiation for the studies in the table. Variant 1 is the initial workup in a patient without or with prior trauma and complaints of chronic neck pain. Only radiography is appropriate. No other studies are appropriate by scores. Variant 2 is a patient with prior malignancy, presenting for initial workup of chronic neck pain. Again, only radiography is appropriate. No other studies are appropriate by scores. Variants later in the clinical topic narrative guide us in the care of patients who already have had the appropriate initial radiographs and return for further management based on those radiographic findings and the patient's clinical context. Variant 5 deals with a chronic neck pain patient whose initial radiographs were normal, but who has paresthesia, numbness, or weakness. This patient should get MR by score. But if they have a contraindication, the table indicates through the comments the next most appropriate exam is a myelogram with CT to follow. Not all cases get MR to follow up. A patient with chronic neck pain after spinal fusion surgery is routed to CT. A patient with chronic neck pain and ossification of posterior longitudinal ligaments on radiographs is routed to CT. But comments flexibly guide you to use MR if myelopathy dominates the clinical picture. Details of all 190 clinical topics and the 900 variants are too much to memorize, and these change frequently with ongoing updates. So it is important to consult this resource regularly to ensure best practice imaging selection and to provide our patients with high-value clinical care. A concise review follows each clinical topic with natural history, epidemiology, treatment, and imaging recommendations in clinical context with recent high-quality references. In summary, ACR appropriateness criteria gives us a high national standard of quality that provides outcomes evidence-based, multidisciplinary, regularly updated, free clinical decision support so you can offer best practice care in your use of imaging. Make it your routine habit to consult the ACR appropriateness criteria when ordering imaging.